There are two types of Q waves: non-pathological narrow shallow Q waves which are not visible in all leads, pathological more than 0.04 second in duration, at least 1/4 to 1/3 height of the following R wave, and represents an infarcted area of myocardium. Pathological Q waves are more than 0.04 second in duration, that is more than 1 mm, are wider than one small box. They are deeper than the R wave by 1/3 of the height of the R wave. They can be new or old, or they can be normal versus pathological, as already discussed. Non-significant Q waves are commonly found in lead 1, AVL, and V6. Significant Q wave is a sign of previous MI. Any Q wave in V2 or V3 is pathological. Q waves should also be present in contiguous leads to be defined as pathological. For example, N2 and AVF, R1 and AVL, or V1 and V2. So the Q wave is any negative deflection that precedes an R wave. Normal origin Q waves represent the normal left to right depolarization of interventricular septal activation. Small septal Q waves are typically seen most leads, especially in the left-sided leads 1 AVL, V5 and V6. Deeper Q waves more than 2 mm may be seen in lead 3 and AVR as a normal variant. Q waves are not seen in the right-sided leads, that is V1, V2 and V3. Pathological Q waves are 40 milliseconds or more in width or 1 mm, more than 2 mm deep, more than 25% of depth of QRS complex seen in leads V1 to V3, usually indicate current or prior MI. However, cardiomyopathies like hypertrophic cardiomyopathy, infiltrative myocardial disease, rotation of the heart, extreme clockwise or counterclockwise rotation, and lead placement errors, for example, upper limb leads placed on lower limbs, could occur and lead to Q waves on ECG.